Afternoon, everyone. Welcome to today's Peers Under Pressure session, the pressure refresher, back to basics of pressure ulcer prevention. Many of you will already know us here at OSKA if you've joined us in our past webinars, and you'll know some of my panelists this afternoon. But if you're new to OSKA, welcome. So without further ado, let me introduce you to my guests this afternoon. I'm delighted to welcome 3 expert speakers in their field. Firstly, a very warm welcome to Alison Schofield.
Hi, everybody. Nice to be back.
Alison is Clinical Manager and Honorary TVN at York Hospital NHS Foundation Trust. Her current role as a Clinical Manager at MOLE involves producing and delivering education and tools for healthcare professionals in all aspects of tissue viability. She's also worked for more than 20 years in community services as a district nurse and a tissue viability nurse. And she has also led a pressure ulcer prevention team in Bradford NHS services. I'd also like to welcome back Carol Young.
Hi.
Carol was the lead tissue viability nurse specialist at Cambridge University Hospitals Trust for more than 20 years, working on a number of regional and national initiatives. She's an associate lecturer at Anglia Ruskin University, teaching tissue viability related clinical skills for pre-registration student nurses. And last but by no means least, welcome to Anita Morton.
Hello, everyone.
Anita has more than 20 years experience in community nursing, teaching and industry, coupled with an extensive background in nurse education, pressure area care and negative pressure wound therapy. Anita truly believes that education is the key to excellence in care. And I'm Emma, and I will be your chair today. So we want you to get as much out of today's session as possible. So if you'd like to share your experiences or ask any burning questions, then please use the Q&A function in Zoom to participate in our discussions. These ladies truly are experts in their field, so take the opportunity to ask the expert. Right, okay, with our introductions done, let's get on with today's session. So the pressure refresher, always a very popular topic, and with the sector being so overstretched at the moment, we want to obviously get as much information out there as we possibly can. So Carol, let me come to you first, if I may.
Hi, Emma.
Thank
you for my introduction, and let's start, I think, the session about thinking about why we're here. I think pressure ulcers remain a huge concern in healthcare, and costs are huge, both physically, emotionally and financially. Patients get a lot of suffering, long stays in hospital, infection, and the costs include nursing care, equipment, dressings, but also litigation costs as well. So we're going to start the session today with reminding everyone about the definition and the causes of pressure ulcers. And for this, we're going to use the recommended definition set by NHS Improvement in 2018. NHS England and Improvement lead the National Wound Care Strategy Pressure Ulcer Programme and have developed a number of recommendations to make sure that we have a consistent approach to used right across England, where we're defining and reporting and measuring pressure ulcers. So the definition is this: a pressure ulcer is a localized damage to the skin and the underlying tissue. And that's really important that we remember that pressure damage starts sometimes underneath the surface where we can't see it. We're going to talk about those reasons why as we go through. Usually happens over a bony prominence or related to a medical or other device. And we're going to talk a bit more about that as we go through this session as well. Pressure ulcers result from a sustained pressure or pressure associated with shear. And in a minute, we're going to go through those two definitions of what is pressure and what is shear. And it's really important that we also remember that damage can be presented either as intact skin or an open ulcer. So it's not always a wound. It might be just a discoloration or a change in the skin appearance. And it might be painful as well, depending on the depth and the nerve endings that are impacted by that damage. Pressure ulcers is the terminology that we're using now, though you might hear, your patients might refer to bed sores or pressure sores still. But it's really important that we explain to our patients and our carers that we don't use that term bed sore anymore, because as we know, pressure ulcers don't always occur in bed, and they're not always sore, but they might be happening in a chair or through a device related as well. Pressure ulcers are categorized as category 1, 2, 3, 4, unstageable, and a DTI and device related. And Alison's going to go through all those categories in much more detail a bit later on. And you might have used terms as stages or grades in the past, but now we're following the NHSI terminology to keep that consistency. We're going to use the term category through this presentation. And it's really important that we keep that consistency in our communication and our documentation. Next slide, please. So let's start to think about what causes our pressure ulcers. Pressure ulcers occur because of two forces that are acting on the tissues at the same time, pressure and shear. Pressure forces happen between the bony prominence and the surface that the patient's in contact with. So that might be the chair or a bed or a device at the surface. Direct pressure, though, is 3 to 5 times greater at the bony prominence rather than at the surface. So the damage in the soft tissues and the blood vessels will happen deep in the tissue, right by the bones, before we see it on the skin and the surface. The soft tissues are compressed, which occludes the blood supply, prevents oxygen and nutrients getting through to the tissues. And this ultimately causes those tissues to die and a pressure ulcer occurs. And the amount of pressure that a person can tolerate can vary. Depends on your size, your ability to move, any underlying conditions, or your existing skin condition. But generally, we can tolerate lower pressures over a bigger surface area for longer than a high pressure over a small surface area. A really good analogy of this is like in the pictures. Someone stands on grass with a stiletto, they'll push through and cause damage to that soil very quickly. But if an elephant with a large round padded foot stands on the same ground, the soil will become less compressed over a wider area. So if we apply this to our patients and the surfaces they're nursed on, the more contact they are in with the support surface and the body, the less of the interface pressure is, because the pressure is redistributed over a bigger surface area. And this is why we move away from those old-fashioned mattresses with the really hard plastic covers where our patients were kind of suspended on the top, to the more modern, moldable, flexible surfaces that we see today, where our patients are immersed and enveloped. And Anita's going to talk lots more about the surfaces a bit later on when she gets to the surface section. Next slide, please. And the other force that's at work is in pressure ulcer development is shear. And this is the force that occurs when the body prominence pushes down through the tissues and causes a distortion or dragging effect on those soft tissues. This leads to capillaries and the cells being stretched or torn. And then cell fluid leaks and causes edema and bleeding into those soft tissues. And you might see this in practice. You might see this dark discoloration on the surface of the skin where those capillaries have leaked and bled. Or you might almost see that sort of sheared, scraped appearance on the skin as well. And shear-related pressure ulcers often appear tear-shaped or stretched, and they happen most frequently when there's also an external force, such as when a patient slides down a bed or a chair, when the skin stays still, but the bony prominence and the soft tissues move forward, and that causes that stretching and tearing. So shearing can be reduced by ensuring that we've got the right equipment in place and that we're using it to its full benefit. So things like our profiling beds, sliding sheets, knee brakes, and any supports that prevent our patients from sliding or moving down the bed. Next slide, please. Now we need to talk about friction as well, although it's not included in the definitions of pressure ulcers anymore, because very often friction can also refer to an injury or a trauma. However, it still impacts in pressure ulcer development, especially when there's shear involved as well. Friction happens when two surfaces rub together. For example, when you go out and wear badly fitting shoes, we've all done that, and they rub your foot, cause a blister. Or if a patient is maybe agitated and fidgety and rubs against the sheets in bed, and they maybe remove the superficial layers of the skin, and that can be exacerbated if there's moisture present as well. Friction damage occurs sometimes as a result of poor manual handling techniques. Particularly things I've seen in practice is we all diligently use those sliding sheets to move our patients up the bed, but sometimes we forget to make sure there's a sliding sheet under the heel, and then that gets dragged up the bed and the patient can get a friction blister. So we need to make sure we're looking after every bit of our patient when we're manually handling them. Next slide, please. So having looked at the causes and the definition of a pressure ulcer, we need to think about how we prevent them. And this needs to be a really holistic approach. We need to consider and manage the key factors that increase the risk of pressure ulcers occurring. And it's recommended that we use a care pathway or model to make sure nothing is missed. NHS Improvement brought a number of different models together in 2018 to create the ASKING model. Now, originally, this was designed to be an education curriculum. I think both me and Alison were involved in that work. And what we realised very quickly that it's a really good care plan as well. So ASKING stands for Assessment of Risk, Skin Inspection, Surface, and the surface includes devices, Keep Moving, Incontinence and Moisture, Nutrition and Hydration, and Giving Information or Giving Advice. We're going to go through each of those aspects in turn. I'm apologising for any background noise. Our ring camera's just gone off very conveniently. Can I have the next slide, please, Emma? So we're going to start with assessment of risk. Assessing our patients is the most important first step in preventing pressure ulcers. A risk assessment helps to identify when our patients are at risk or if they already have pressure ulcers and who we need to focus our interventions on. Next slide, please. So why do we do pressure ulcer risk assessments? They enable us to early detection of our individuals who are at risk and those that have got pressure ulcers. NICE guidelines state that a risk assessment should be undertaken as early as possible when somebody comes into accessing healthcare. So they recommend that a risk assessment should happen within 6 hours of admission to hospital. How easy is that when our patients are in ED for many, many more hours than that? And or the first visit in the community. And that can be challenging as well. Our community staff sometimes only have a few minutes to complete an insulin or a catheter check. So it's very challenging for them to do a risk assessment as well. And the NICE guidelines advise that a formal tool should be used alongside clinical judgment. What do we mean by that? And what's the difference between a formal tool and clinical judgment? So a formal risk assessment tool have the advantage of being a validated, repeatable, and reliable. They've been researched and evidenced, but they give really clear prescriptive guidelines, and they're quite easy to audit. And they're easy for someone to do if they haven't got a wide range of experience. They ask questions, they give a score or an answer or follow a pathway down. But on the flip side, they can be criticised as being not very personal to individual patients. And sometimes health professionals can become very reliant on the score. And so they use that score to prescribe care rather than using their clinical judgment and their holistic assessment skills to make sure they're covering all aspects of their patient care. The clinical judgment then is much more around our holistic and our observational skills, but it does require a background of knowledge and experience. It's sometimes referred to as that gut instinct or that nurse's intuition. Sometimes we just know by looking at our patient that they're going to be at risk. We know if they're not moving very well or they're not rolling over in bed. We'll know that they're going to be at high risk without having to do a score. But that can be quite challenging if you're a brand new member of healthcare profession, you haven't gained that experience and knowledge yet. You maybe don't know what those risk factors are. So that's where your tools can be helpful. So a really good pressure ulcer risk assessment should combine the formal risk assessment tools with your holistic clinical judgment. And your risk assessment will enable a plan of care to be formed and implemented, and ensures the right equipment can be put in place to meet our patients' needs. Next slide, please. So who is at risk of developing pressure ulcers? Well, the short and quick answer is everyone. Anyone can be at risk of developing a pressure ulcer, from babies through to the very elderly. But some people are going to have more risk factors than others. So any patients with a long-term condition such as diabetes, health disease, a respiratory condition, or poor vascular supply are going to have high risk for tissue breakdown. Anybody with paralysis, a spinal cord injury, maybe loss of sensation after a stroke, or if they've got reduced mobility, if you can't feel that you're uncomfortable, you're not going to try to move, or you may not be able to move. Anybody who's critically ill in hospital is going to, when you're in critical illness state, your blood supply and your nutrients all go to your vital organs, so your lungs, your heart, your brain, and your skin tends to get a bit forgotten about by the human body. So it's more likely to be vulnerable. And if you've had recent surgery, you might be in pain, so you might not feel the inclination to move. You might just got yourself into a comfortable position where that surgical wound isn't hurting and you won't want to move again. Our patients who are malnourished or dehydrated, those who are incontinent are high risk. The skin is very vulnerable if it's moist. And those at the end of their lives, as their organs are failing, skin is our largest organ. So that will fail as well at the end of life, and we'll see tissue breakdown then. Anybody who's had a previous pressure ulcer is going to be very high risk, because that scar tissue where that previous pressure ulcer is healed is never going to be as strong as if it was unwounded skin. And there are many psychological and social factors that can increase people's risk as well. And pressure ulcers can also occur under medical devices, as we saw in the definition, such as oxygen tubing, catheters, splints, even compression stockings if they're the wrong shape or size, prostheses, plaster of Paris, those sorts of things can cause pressure damage. So this list is not exhaustive, and that's why we need that holistic assessment. And it's so important that we're looking at all of the factors that can increase our patients' risk. Next slide, please. So alongside our risk assessment, we need to be thinking about our skin and our skin inspection and skin assessment. We need to physically assess our patients, and this is our next element of the asking model. And it should happen around the same time as our risk assessment, and then at every opportunity. We want to be doing skin inspections whenever we can see a bit of skin. So imagine if you're helping somebody with a wash, or helping them to dress, or maybe taking them out to the toilet. Any of those opportunities are good times for us to have a look at patients' skin. Next slide, please. So when we do a skin assessment, it needs to include a number of factors. We need to look at the dermatological. What is the skin condition? Is it healthy? Is there an underlying skin condition? Is there already damage? The psychological, is there anything with the patient's mental health or mental well-being that's impacting on skin condition? And social, is there anything in the environment or any medical conditions that might be impacting on their skin health? But unbelievably, about 54% of the UK population has a skin condition in any given 12-month period. That means about half of us here today are likely to get a skin problem at some point in the next 12 months. But even more surprisingly, only about 14% of those people will actually seek medical help for that skin condition. The rest will use, creams and lotions and potions and try and manage themselves. So as clinicians, we need to be very aware of that, and we need to use some of our senses and not just looking and using our sight, looking for discoloration, any signs of skin breakdown, moisture, dryness, what equipment and devices can we see in contact with our patients. But our other senses, our hearing, we need to listen to our patients. What are they telling us? What's their story? What's their history? Are they telling us they're in pain in a particular area? And we know that pain is an early indicator of pressure damage. Smell, is there any odor that we can maybe give us an indication there might be infection or fungal ingrowth? Or maybe odor that indicates our patient might be struggling with their personal hygiene or incontinence. Lots of things might give us a few clues. And then touch. What does the patient's skin feel like? Is there a bogginess or a firmness? Is there any edema or heat? Does it feel different to the surrounding tissues? Doing our skin assessments early means that we're able to detect pressure damage early. Skin inspection needs to happen frequently, not just a one-off. We need to make sure we're involving our patients and their carers as well, so they know what to look for or how it might feel if the pressure is starting to have an impact. And we can introduce them to using things like mirrors to look at their own skin. Looking at heels is particularly challenging sometimes, and a mirror can be quite handy. Next slide, please, Emma. So when it comes to assessing different skin tones, this can be challenging as well, especially if your patient has a different skin tone to your own. You might not be used to knowing what is normal on pale skin or dark skin. And it's really good news that both nationally and internationally, this has got a much higher profile at the moment. We've got guidelines being produced both nationally in the UK and internationally. This really busy looking document, I'm not expecting anybody to be trying to read all the writing on here. This is way too busy. But this is the Pan-Pacific pressure injury classification system for dark skin tones. And what I'm going to just draw your attention to the pictures at the bottom there. It does show us quite nicely what different categories of pressure ulcers look like or might look like on darker skin tones. And you can see that a category 1 or a DTI is actually really difficult to spot, whereas actually an open wound from category 2 through to category 4 are really defined because those internal tissues are much paler and really stand out. So in practice, what we see sometimes is that early categories of pressure ulcers are missed in dark skin tones. And the first thing that we see is a category 2 or above pressure ulcer when it's that open wound. So it's really important that we consider the other signs of pressure ulcer development, so things like pain, bogginess or firmness of the tissues, and compare with other areas. So maybe looking at the right buttock compared to the left, do they look the same? Or is there a subtle change in the colour? The left and right heel, for example. But particularly take note of pain. We know that this is an early indicator, and particularly in patients with darker skin, this could be our clue that something's not right. Next slide, please, Emma. So in the UK, we've also got the recently published best practice statement, which gives information on a wide range of different skin tones that we might see. And this is the most current one at the moment, but it is being updated as well. So there'll be a new one coming out very soon, we've been told. You might also want to look at a really good book called Mind the Gap by Bakwende et al. And he's a doctor who put a book together to help clinicians identify a number of different skin conditions, particularly in darkly pigmented skin. Next slide, please. So finally, for my bit, you're going to look at where do pressure ulcers mostly occur. When we're doing that skin inspection, where are we looking? In the definition at the beginning, we identified that pressure ulcers occur mostly over the bony prominences. So it's worth us just looking at these body maps and reminding us of where those bony prominences are. What is that anatomy? What are the names of those different places? And the most common sites of pressure ulcers tend to be in the lower trunk region. So the sacrum, the trochanter, the ischial tuberosities, hips, those pelvic bones. And that's often followed by the heels and the malleolus as the next most common place. And heel ulcers can be often complicated by other vascular conditions or diabetes and can end up with amputation. So it can be pretty serious. But also think about those other areas. Think about elbows, particularly if your patient leans on a table like this or on the hard arms of a chair. Arms, knees and shoulders can be particularly at risk if people are laying on their sides for long periods of time. And if you work in critical care areas, you might be used to seeing patients being nurse prone, particularly since COVID. We've seen a lot more people being nursed on their bellies. So areas that we never used to see pressure ulcers happening, we're now seeing pressure ulcers on the chest, on the genitals, on the tops of the feet where they're face down. And devices will affect other areas. So think about the ears with tubing, the nose, and even digits, oxygen sac probes, compression hosiery, stockings can cause problems there as well. But I'm going to hand you over to Alison next, and she's going to talk about you through categorizing those pressure ulcers.
Ladies, before we move on, we've had one question, and I think it's probably an ideal opportunity to ask it now. One person has said, apologies, what did you say friction is not included in anymore?
So friction is no longer included in the formal definition of a pressure ulcer. So it used to be pressure, shear and friction, and internationally the term friction was removed because it often refers to a traumatic wound as well as pressure.
Thank you. Alison.
Next slide, please. Thanks, Carol. That was a great update. Do you know what? I mean, as long as we've been working specifically in this area of care, it is always good to go back and revisit kind of the fundamentals and things. So that was really great for me to personally listen to. So so moving on to the individual categories. And so we'll categories don't go uniformly as in 1, 2, 3, 4, but we will go through them just to describe them in that particular order. So a category 1, and we've got some really great images in this presentation as well, so we can see the images there on screen, and we've got, as Carol was just talking about, with dark skin tones, we've got some images here to show the differences, particularly around category 1 and deep tissue injury when that occurs on the skin. So on a category 1, the skin is intact at this point. There are no breaks in the skin integrity. So what we can visibly see, we can see on one of the pictures there where the area appears sort of a red, so it'll be a red or a pink. This image is of somebody's buttocks and sacral area. And then with the skin of a dark tone, this area may appear like a blue or a purple colour. But what's important to remember is what's happening here is that we've got inflammation and classic signs of that. So the skin is, it's under pressure, well, literally. And you can see from the diagrams there of the sections of skin. So we've got the 3 main sections of skin, the top layer there being the epidermis, which is only around 3 millimeters thick, which is like a piece of paper. Then the dermis, where we've got lots of activity going on. So there's no blood supply in the top layer epidermis. That all happens in the dermis. We've got the hair follicle roots going on. We've got the nerve endings. And then below that, the subcut fat, and below that, the bone and muscle. So for the inflammatory category 1 stage, it's that epidermis into the dermis that we're concerned with. So the area might feel when we touch it, and Carol mentioned all those sensors, so important, not to just be looking at photographs even. If we can, we need to be touching and feeling. So with inflammation, we might get edema, so it might feel soft to touch, or we might get what is called induration, so it feels firm to touch. The area may feel warmer with heat and inflammatory processes, or if it's on the lower extremities, like on the feet, it may feel cooler because people have got vascular compromisation. These can develop very, very quickly. So it's our red alert sign, if you like. It's an alert to say, right, we need to do something. We need to make sure we've got provision of equipment. We've got repositioning going on. We don't want to put dressings on these wounds. As I said, the skin's not broken, so we don't need to cover them. And if we do cover them up, we can't see them. So, you know, we can leave them open. People will often say, well, can you use creams or, you know, so emollients? Yes, you can, because if the skin's dry, then it will keep it nice and supple. We can use barrier products that are used for moisture-associated skin damage. That's coming up a bit later in detail. You know, it won't harm to use that. But if it's on a bottom and there's incontinence involved, let's not be putting loads of Sudocrem onto the area, because one, it'll clog the continence pads, but you can't see then the changing colour of the skin, because it just turns everything white, and you've got to rub it and scrub it to get it off as well. So we need to observe and monitor. So put your Sherlock Holmes hat on and you know, find out what's going on. This is your earliest opportunity of visual signs. So if you can see and feel something, the patient, listen to the patient, what they're saying. Are they saying, oh, we've got pain? Ask those questions. How are your skin? How are you feeling? You know, if they're sat a lot, or, you know, ask the questions. And if you eliminate that root cause, you know, then we can stop further damage from being prevented, because we can see it at this point. But I can tell you from evidence and research that has happened that there is earlier pressure damage. We cannot see it. Pressure damage occurs within minutes of somebody being at risk and that being there, and it's called deformation. It's an actual scientific process. You know, this is when we see it then down the line. So let's be happening. Let's react to risk. And can we not really be using the terms react to red any longer, because we know that then there is you know, a skin tone bias associated with that. Next slide, please, Emma. So when we're looking at that assessment of skin for those early signs of pressure ulcers, so on a lighter or pale skin tone, we do what is called the blanch test. So blanchable erythema, we use that to detect that inflammation. So that's when those cells, they've already started to die, and then we, you know, that process of that necrosis by apoptosis, it's called, where the cells send signals to each other, and then you get that deformation that's occurring. So what we can do in practice is, if we see, for example, here we've got a picture of somebody's heels. If we see that redness to the heels, then we do that gentle press with the finger. And if the microcirculation has been affected, then that redness to the area will stay as it is. When we remove our finger, the area comes back to its normal colour. You know, that's the blood reacting through the blood vessels. So the microcirculation is intact there. So there isn't any pressure damage. And, you know, if I'm sat here, right, I've just crossed my legs over. So if I sit here for a bit like this, and then I remove my top leg, my knee underneath is going to have a red mark, but that colour will quickly come back to my normal tone because I haven't got pressure damage. But obviously, if I left it there for a heck of a long time and I've got risk factors, then I might get some pressure damage occurring. So that's the blanchable test that we do. And in a dark skin tone, as we said, localized colour changes. We can see there some images of kind of a purple or a blue type of colour, but, you know, do that touch and feel. Next slide, please. So this is category 2. Now, category 2 is very superficial skin loss. So think again, let's look back at those, the diagrams on the screen there of the skin. So the epidermis, the dermis, down to the subcutaneous layer. So we're talking again, so we talked about category 1, no break to the skin, but here we've got the skin integrity break, but we're only through down to the epidermis. It's literally like, you know, kind of peeling off that top layer of skin, if you like. Or it might appear as a blister as well. A clear-filled blister would be a category 2, and as Carol has explained, you know, that friction association has been taken out of there, but with shearing processes, we might see a clear-filled blister occurring. Often on the heels, you will see those there. So we're into the dermis layer, and there's always been a debate around, well, what if you've got slough? Does that mean it's a category 3? Well, you know, what is slough? Slough is a yellow substance that you'll see on a wound. It's when we're in the inflammatory process, we get white blood cells and lots of cellular activity rush into the area, and we get bacteria on any opening to the skin. So all of that amalgamated together forms slough. So can you see slough or not? Yes, you probably can see it in a category 2, but it is about the depth of tissue loss. And you can clearly see here, you know, that it is just a superficial layer that we have. Next slide, please. I just say that in you know, in all these skin checks, just with, you know, with our patients, who we check. Patients are our patients because they have vulnerabilities in all of our settings, but just to have that extra vigilance with people who have higher risks and that altered sensation, like Carol did mention, you know, with diabetes, with spinal injury. And when we're looking at the skin, and this picture is a really good example in the category 3, we've got that picture there. It's on my left, and it's of a pressure ulcer. Looks like to the hip to me, and around there you might think, oh well, there's scar tissue there. Is that from a previous pressure ulcer? Because previous pressure ulceration, if somebody goes back to then their seating for long periods without relief, or lying long periods, heels in the same position, they're more likely to break down again if they've had that previous pressure damage. So on that picture there, it looks like there's scar tissue, or, you know, elements of the ulcer that's there is healing. Looks like on the top edge, it's kind of rolled inwards, which suggests it might be a chronic wound that's been there for quite some time. So it can tell us so much by that, looking at the surrounding skin as well. So category 3, we've got full thickness skin loss. So again, on our skin diagram, you can see we've come through the epidermis, dermis, and then we're now down into that subcutaneous layer, or the fatty layer. Also has blood supplies and lots of activity going on in there. If you can sometimes see that when you've broken through the tissue to this depth, and it might look a bit like baked beans. I don't know why do we do this, Carol and Nita? We associate things in wounds with well, I do with food. Slough looks like custard sometimes, and things are enough to put everybody off their tea. But yeah, subcut fat, look out for the baked bean. But we don't have bone, tendon or muscle exposure at this point. We can't feel bone, we can't see it, we can't see that muscle, because we are not down under that subcutaneous layer. We are not down into that level. Now it says here on the screen, tissue viability nurse would need to review and assess these pressure ulcers. It depends on your setting, if I'm quite honest. So if you are in an acute setting, acute hospital, NHS, on the wards, and we're reporting you know, our pressure ulcers as we do, then in those circumstances, usually for category 3s and 4s, a tissue viability team would be coming to assess those. I've worked predominantly in community, and in some areas that's been the case, but not all. You know, and again, I know some of you here today are from nursing homes and hospices. So, but what I will say is, if you have severity of pressure ulcers, you have deteriorating wounds that have no signs of towards healing, then please do refer for that specialist wound input, you know, to aid you in that management. There are things we can do to kickstart healing, and also into relief of the pressure that's possibly already there. Next slide, please. And we have category 4, which is obviously our most, what we call it, our most severe category. But, you know, all pressure damage is of a severity to patients. And sometimes the categories 1 and 2s can be more painful because of that, in the exposure and the damage to the nerves in that dermis layer. And sometimes at category 4, people can sometimes lose that type of sensation with it. So we can see now on the skin diagram, we've come right through down the layers of the skin, and we're now broken through, we're into that bone, tendon and muscle. Now remember how the pressure damage occurs, and Carol was describing it really well, and it's like, if you think of, I always think of it like the Titanic. So it's like we call it the McClement's cone effect. So if you think of an iceberg in the Atlantic, you know, you can probably see the tip. Well, if the Titanic had seen the tip, they wouldn't have been in so much trouble, would they? It was far too late. But underneath, it's underneath where you've got the most of the iceberg occurring there, what we can't see. It's the same with pressure damage. We might see that break or redness to or discoloration to the surface, but it's those tissue depths underneath where the amount of pressure at the bone through is then what's causing the problems, and it can get to like this if it's unrelieved. It can be acute or chronic. So if somebody, for example, has a fall and then not that slide, please. We can go back. Thank you. If somebody has a fall and they having a long lie on the floor, then, you know, they could then end up being admitted and they've got a category 4 pressure ulcer from that one incident, or it's developed over time and then it becomes stuck in that inflammatory process because there's other things going on and it's non-healing. It might have tunneling and undermining, so to the edges there might be little tunnels and tracks go off. So when the wound assessment's been done, it might be that a probe's been used or a gloved tip of the finger just to kind of go around the edge or to assess where the measurements go in. I've seen pressure ulcers where, even around the buttocks, where you've got one great big pressure ulcer like that on screen, and then you've got another area below it, but they tunnel and interact with each other, which can be tricky in the management of that. And, we've got incontinence and all sorts of other things going on. So, they are detrimental to the patients and patients' families and carers. It can affect their overall emotional well-being. Then obviously that will have then a knock-on effect to the patient. And category 4s may result in infections, in bone infection, osteomyelitis. So people may need to have scans for that and treatment for that. Hospital admissions, amputations, Carol mentioned, especially if somebody's got diabetes and it's around the foot area, surgery and even death. I have unfortunately witnessed patient cases where they have died from having severe pressure ulcers and resulted in sepsis. Next slide, please. And then we have unstageable, and this is the one. Unstageable deep tissue injury are the two that people often say, oh, I just don't get it. I kind of get confused with that. So unstageable just means that we can't stage it because we don't know exactly what the depth of the tissue is, because it is covered or obscured by necrosis or slough. So we've got two wonderful images there on screen. One is of a heel and one is of a buttock. So you can clearly see that black tissue type in the middle, the coverage, necrotic tissue, which is basically just dead tissue. It often looks and feels a bit like leather. It might start to soften up and come away, and then we get this quite strong malodor with it. Or it may be just a very thick, virulent slough that's on top of the wound bed, and we know it's going to be at least a category 3 because we've got this occurring. It's going to be a 3, it might be a 4, so we report it as, and we call it unstageable. So we want to review this, monitor it, keep an eye on it. Now, in some cases, we may use debridement to get rid of that, but I would advise to speak to wound care specialists about that, especially in wounds that are like these on the screen, to see if that's appropriate and what methods are used. With debridement, there are many different ways and types of doing that. And if it's been done by, for example, a Sharps procedure, that would need somebody who is highly skilled and trained in that, like a podiatrist, the vascular services, or tissue viability, myself and Carol. do that as well. If it's something that is on the lower limb, so like that heel unstageable ulcer there, then I wouldn't go near debriding that until I have done a full vascular assessment, including a Doppler, because I want to know what is the arterial status of this patient, what's their history, are they diabetic, because I could make that much worse. In some cases, this can be like the body's sort of natural protection, even though it's unvitalized tissue, you know, in time, if left alone, the wound may have some healing underneath, and that might just peel away. So, you know, do get advice and support. But you can see again from the skin diagram, you know, the damage underneath that top layer we can't see underneath is right down. You know, it's definitely into you know, a deeper type of damage. Next slide, please. And here we have our suspected deep tissue injury, and we can see again, you know, looking at those images, especially the first one, you think, oh, we can see that kind of purple maroon discoloration, but look at the skin diagram. You know, deep tissue injury, the clue is in the terminology. It goes right down through to those depths. So, you know, act quickly when you see something like this to resolve it. If it's on the feet, get them fully offloaded. I would say with that heel one there, I would expect that to resolve if we get proper good offloading. But that one on the foot, we've got a purple or maroon coloured blister, intact blister, which we can get is a sign of deep tissue injury as well. You know, that one may break, it may evolve, or, you know, if left alone, it may just, the fluid may reabsorb and back into the body, and it may go flat. So, you know, do get advice and support for that. And these are reportable as well. We do need to be reporting these. I was just seeing what that question was. What stage of pressure sore would you use? Oh, I think it says botties. I think it means booties on the feet. I know Anita's going to look at equipment. If she doesn't cover foot protection, we'll put that into the question chat at the end, and we'll otherwise I'll go off on a tangent and I will forget where I am. Next slide, please. So the device-related pressure ulcers, and Carol briefly mentioned this and some of those devices that may be involved. I just want to draw your attention to a document you can Google and find, and it's the international consensus document called Secure Prevention. SECURE, as in secure, and it's produced by the Journal of Wound Care, and it's got lots of amazing experts that have come together to produce that, and it's specifically for device-related pressure ulcers, so it covers everything. So yes, it might be nasogastric tubes, it might be catheters, we see a catheter on screen there, it might be ventilation masks, anything kind of plastic, silicone or rubber. I mean, even the string on, you know, our masks that we've all been wearing and still wearing in practice, you know, even clinicians, we experience pressure damage around the face, round the ears as well. So anything that has the ability to cause pressure. That picture of the toes there is fascinating. Do you know what that is? That's bed sheets that are too tight on the bed that have caused that. So, you know, let's not restrict too much. Look inside the beds. Is there any buttons or, you know, coins or crumbs or, you know, I do always tell this story, but we had a patient who had false teeth he'd slept on in the bed, and, you know, it's a beauty of a shape of a deep tissue injury, but it could be anything, I think is the point. So, you know, straighten out the creases in the sheets and just check around in the chairs. You know, bed rails, I've seen them on the side of people's knees where they're pressing on bed rails where they might have contractures and they can't move their legs themselves. And, you know, treatment for these again is, you know, that it might be that it's a barrier product is a good thing to use, like a spray, silicone pads, you know, types of dressings. But again, that secure document does cover a lot of that in great detail. And also mucosal membrane. You see that with the image with the patient's nose there. It doesn't have the same structures as the rest of the skin, so that can be one area that we see damage as well. Next slide, please. So heels, you know, just to mention heels in, you know, out of the anatomy of everything, because the way the heel is shaped, our heel bone, the calcaneus, it has a lot of pressure through it, you know, day to day. You know, we're walking about, or people who can't walk about so much, you know, they might be resting their heels up on a, you know, an inappropriate surface. It takes a lot of pressure through it, you know, it has a lot of hammer. And the tissues around the calcaneus, the heel bone, is very vulnerable. There's little muscle and fascia, not as much subcut fat, so we can see damage occurring really quickly. And also, if people are prone to like shuffling, moving their feet, you know, if they've got dementia or Parkinson's, you know, whether that's in bed or sat on the chairs, people slumping chairs have got the heels down on the floor, you know, again, that friction, we can see then damage occurring through that. We have a small circulation of blood vessels in the feet, and if there is any risk factors to that, so diabetes, rheumatoid arthritis, I could think off the top of my head, then that microcirculation may already be damaged, got neuropathic nerve damage going on. They might not be able to feel it, and, you know, quickly like that, you know, that any wound or pressure to the area can result in severe in injury and sometimes amputation. So remove the socks, get the slippers off, and have a good look round the toes, sides of the feet and the heels. If they've got splints or braces on, speak to whoever put that on, such as the orthopedic department. You know, can they be removed to check and then put back on? How do we do that? And if somebody has a cast on, you know, they've broken or fractured a bone and they've got to have that on. If somebody's complaining of pain or showing visual signs, I remember I used to cover schools and learning disability schools, and we had a boy in there, and he was about 7, and he'd had a fall and he had a cast on, but he didn't have verbal communication. He kind of just with his eyes would blink if there were things wrong, and his mum knew there was something wrong, and they went back, took the cast off. He got a category 3 on his heel because it wasn't fitted right. So, you know, do be aware of things like that around the feet. Next slide, please. I think that's me done. Oh no, reverse categorization. So there's a just popped up there as well. If you answer that while I just go through this and then hand over to Anita. So I said at the top of that, categories don't just come uniformly 1, 2, 3, 4. You know, they can pop up at any point if we can, because we might not. I used to work in community. I was a district nurse and tissue viability nursing community for years, and you know, we won't see people every day necessarily, so we can't perform those skin assessments every day. So things can change very quickly in you know, that time lapse. And also reverse categorizing. So once a pressure ulcer is, for example, a category 3, it's always a cat 3. It's a healing cat 3 or a healed cat 3, because that is how, you know, if it can't then, you know, oh, now it's a 2, and then now it's a 1, and now it's healed. Because the way a wound heals is, a wound will fill in with granulation tissue. That's the process. So we've got that nice angiogenesis, capillary loop formation, granulation tissue fills in the cavity, and then we've got the epithelial cells which come together, leapfrog over the top with moist wound healing, and then it will come and contract together, and we get that scar tissue over the top. So it's like having a brick wall, and we've got a hole in the brick wall, and we just fill it with cement instead of putting the bricks and everything else back into it, you know, to make it strong. I think, oh, that'll do, fill it with cement. Then we've got winter, we've got rain and storms and everything, and then it wears it away, wears that cement away. It's the same analogy. If somebody goes back to then just their normal routine, that tissue, that skin will break down again. So keep your care plans up to date with wound assessments. Take photographs where you can, because, you know, the pictures do tell 1,000 words. And, you know, remember, if we haven't documented it, then we haven't done it. So make sure we're kind of up to date with that. And I believe I'm going over to Anita now.
Thanks, Alison. Yes, so thank you, Alison and Carol, for your input. It's been, yeah, like Alison was saying, it's always good to go over everything, and I think just for us in general, I think it's always nice just to kind of reaffirm that knowledge in your head. So yeah, thank you for that. So let's have a look at surface selection and use. So the next S in the asking bundle being support surfaces. So next slide, please. So really, this is about looking at the different types of pressure relieving equipment, or should I say support surfaces at this point, and kind of where we start and where we sort of finish in terms of risk factors. So I suppose the very first rung of the ladder, as it were, is our pocket sprung or foam mattresses. And these mattresses they're the mattresses that we go out, we buy, we use because we are fit, we're healthy, and we're able to move around. They aren't medical grade in any way, so they aren't suitable for anybody who would have existing pressure damage or who would even be at risk of pressure damage. But they're fine for us because we're able to move. So you might think, well, why am I mentioning those then? Well, I'm mentioning those because actually a lot of the time our patients, our residents will come from their own home and come either into a hospital. They might go home and be assessed for another type of surface that they aren't used to. And also it could be that they're coming straight from their home environment into a care home, nursing home, etc. So we need to be mindful that our patients and residents will actually, you know, have experienced a pocket sprung or foam, I say memory foam mattress prior to then going on something more medical grade, and that actually might feel quite different. So it's just about being mindful of having a conversation, if you're able to have that conversation with that patient or resident around why maybe you're using those support surfaces instead of those standard mattresses. So the first sort of medical grade mattress that you may see would be the pressure redistributing high spec foam or maybe viscoelastic mattresses. And these are high spec mattresses. So I've got their high spec foam mattresses, but like I say, they could be viscoelastic as well. So these are suitable for people who are identified at risk, potentially high risk from a prevention point of view. But again, these mattresses rely heavily on people being able to move themselves. So they're not suitable for people who cannot reposition or maybe have existing pressure damage. And that's because on these foam mattresses, as much as we want them, and they will envelop and immerse the patient into those surfaces, and we want that immersion and envelopment because that helps to reduce those interface pressures that Carol and Alison talked about earlier. But what they won't do is necessarily reduce peak pressures. So over time, peak pressures or over bony prominences can still build. So what we're looking at is we're relying on our residents and patients being able to move themselves to obviously negate that from happening. If we then find that our patients and residents become more vulnerable and actually are higher risk, then we might look to use something called a reactive pressure redistributing surface. And again, these can be foam, they can be static air, they might even be gel. But these are suitable for those residents or patients identified as medium to high risk. And they may have some ability to move, but not all the time. It just might be that they actually can't tolerate a dynamic system, so an air mattress. And actually, this is going to be the next best option. And so from the reason they're called reactive surfaces is because they react to patient repositioning. And what they aim to do is keep a constant low pressure. So whatever position somebody is repositioned into or moves into, that pressure, the interface pressure remains at a constant low. And as Carol said earlier, as human beings, we can tolerate lower pressures for a bit longer. Obviously, we can't tolerate high pressures for very long. So that's the idea behind reactive surfaces. And again, we have that immersion and that envelopment that enables us to get more body contact with the support surface, and therefore we get those lower interface pressures overall. And for those patients and residents who then are high to very high risk, might have some existing pressure damage, so we may be looking at those category 3, 4 pressure damage. At that point, we may then look to use an air mattress, or you may hear them being called active mattresses, or like I said, dynamic mattresses. And these mattresses are pressure relieving. So the other mattresses we've talked about, the medical grade mattresses, are pressure reducing. So they aim to lower the pressure, but they don't aim to completely relieve it. Obviously, at that point, you're relying on repositioning, manual repositioning of your patients and residents. For air mattresses, you will still absolutely need to reposition your residents and patients. However, it may be that you can lengthen periods in between repositioning for some residents and patients, because ultimately, as and when air cells are inflating and deflating under patients, as an air cell deflates under the patient, it helps to offload that area. So it will be really good for those high to very high risk individuals. The only thing to mention with air mattresses is that as and when the air cells, the inflated air cells, are supporting the body, they have to go a little bit higher in pressure in order to do that. So actually, sometimes we will find that patients can find them uncomfortable, that they might be digging in places. So it's about, therefore, looking holistically at what type of support surface is going to be most appropriate, because not everybody will need an air mattress. Not everybody will feel comfortable on an air mattress. And that might be from the noise perspective. It might be from the feeling of the mattress in terms of those hard cells, or the feeling of hard cells in those inflated air cells. It also might be the movement. And actually that can sometimes make people feel a little bit seasick. So you need to look holistically at what support surface is going to be most suitable, because remember, support surfaces are just one piece of that jigsaw puzzle in terms of pressure ulcer prevention. So, that will be coupled with all of those elements that we've talked about in terms of assessment of risk and skin inspection, but it will also encompass the other things we're going to talk about, which is nutrition and hydration, the moisture on the skin, and also about how often we're repositioning somebody as well. So, or if you take anything away from this section, please remember to look holistically at what you're using for your residents and patients, and make sure it's most appropriate. Next slide, please. So the key really is to ensure that your support surfaces will aim to reduce those interface pressures. So we're looking to reduce pressures so that our patients and residents can actually tolerate pressure, those lower pressures for a little bit longer. Because ultimately, I suppose in theory, you could nurse somebody on a plank of wood if you turn them often enough. But ultimately, we don't want to be turning our residents every couple of seconds to offload the pressure. So, if we can use the right support surface, again, we get that good immersion, that good envelopment, which is really key. And it enables us to maybe leave a patient or resident in a certain position for a little bit longer, for their own dignity, for potentially comfort as well. Obviously, that, like I say, that doesn't mean that we don't reposition. We absolutely should be doing that. And again, that will come down to your risk assessment, your holistic assessment of your patient and residents, to how often you would reposition them. So we still need to regularly offload, like I said, and we'll come on to the keep moving section in a moment. But like I said, please ensure that you're using your risk assessment and your own clinical judgment along with your holistic assessment as well. And it really is a case of thinking holistically around the type of equipment that you're using. Next slide, please. So if somebody is on a pressure relieving or reducing mattress and they're sitting out, then they really should be using a cushion as well. And this is to ensure that we get 24-hour pressure area care. It was mentioned earlier that obviously, if you haven't got good body contact, you haven't got a big big surface area, for pressure to be redistributed on, then that creates a high pressure, that creates a peak pressure. And actually, when somebody is seated, and so in a chair or even sat up in bed, what you'll find is that we have about 75% of our body weight pushing through an 8% body surface area in our bottom, and actually that creates a high pressure. So if we are sitting somebody out, that means that sacral area, the buttocks, the ischial tuberosities, your trochanter, your hip bones, all of those lower trunk areas are really at risk of pressure damage. Actually at risk of quite severe damage, because not only at that point have we then got pressure pushing through, but we also might have shearing forces at play as well. So the idea is to use a cushion to help with that immersion and envelopment, increase that body surface area, increase the body contact with the cushion, and therefore lower the pressure. Because like both Carol and Alison mentioned earlier, we know that at the bony prominence that the pressure can be 3 to 5 times greater than that at the interface. So we can't necessarily see or do anything about that internal pressure, but what we can do is use cushions and mattresses to manipulate and reduce the interface pressures. Next slide, please. Oh, before I carry on, booties. There was a question about booties and when we use booties. To be honest, you should be using booties, obviously to offload heels, whenever you feel, see, hear those first signs of damage. So it could be that you're unfortunately seeing it at category 1. Ideally, if we can assess and inspect the skin and ask questions around that regularly enough so that we can detect things early enough, it may be that we're finding that the heels are feeling painful, they're feeling sore, or they're getting marking rather than actual category 1 damage. And at that point, I would be starting to think about offloading those heels. Ultimately, you can use booties. Again, it comes down to that holistic assessment as to what is best for your patient and resident at that point. The one thing I would say is we are trying to steer clear of using pillows to offload heels. Obviously, if that's all you have to hand, then use them, because that will be the best thing you can do. But as soon as you can get something else that actually helps to offload and keep the pressure off, what you find with pillows is that over time they start to flatten, and pillows aren't always really nice and puffy anyway. And so actually you'll find that the heels can quite quickly go back onto the mattress or surface that they're on. So ultimately, we want to try and steer away from those. Booties are a good option. There are wedges that you can put in the bed as well. It comes down to what is best for your patient or resident at that time. Next slide, please. So keeping moving, like I said, we will always need to be repositioning and encouraging our patients and residents to reposition themselves if they're able. And we should be doing this for all patients unless they are contraindicated otherwise. And it needs to be individualized. So yes, we do always look at this 2-hour rule for repositioning. That seems to be people's go-to. But we need to be looking at that individual themselves and how often we need to be repositioning. How often can we encourage them to reposition themselves? Because everybody's anatomy is different, it will vary. And so we need to think about how often we're offloading certain areas of the body. And what sort of regime is suitable for one patient is not necessarily going to be effective for another. So we really need to think of individualized care in that respect. We can use equipment to help with repositioning. So the functions of profiling beds can help. If we're raising the head, raising the knee break, we can use those to help with repositioning. We need to try and avoid raising the head over 30 degrees because that can kind of cause a slouching position and place a lot of pressure on that sacral area, which obviously we want to try and avoid. And I would always encourage and say that you should be raising the foot end of the bed as well, slightly to delay any potential moving down the bed, and obviously to try and reduce shear forces as well. And if we've got any patients or residents who are able to reposition themselves, how often are we encouraging that? And we need to be encouraging that regularly. So we ideally should be encouraging this every 15 to, that should say 30 minutes, not 3, every 15 to 30 minutes. And I know in the throes of a shift that can be really difficult. So it may be about using those kind of visual cues as well. So I always remember as a community nurse, kind of using ad breaks and sort of saying, because they always used to watch TV and it was always this morning or something that was on. And I just used to say, you know what, as and when an ad break comes on, if you can kind of shift yourself around, maybe lean from side to side, if you can stand up and have a little walk, if they are able to mobilize safely, then, it's all about how often we can encourage it. And also, don't forget as well, if you're taking somebody to the toilet or you're walking them to the dining room, these are all, I suppose, informal times that we are repositioning our patients and residents as well. But not only do we need to think of those kind of physical movements that we're doing, we also need to think about things physically on the skin as well. So are there any zips and buttons and seams or wrinkles, like Asma was saying, in the sheet that we can smooth out, any tight clothing that might be causing potential pressure damage to the skin? And how often are we inspecting under those areas? And with slings, that we might be using for repositioning and for manual handling purposes, and ideally we should be removing those slings. I know there are some cases where that can be quite tricky to do, and if that is the case, we need to be looking at, has that sling got seams? Are those seams digging into the skin in any way? Is there any way that we can remove that? Can we negate that from happening? And how often, again, are we checking the skin to ensure that we are making sure that no marking is happening and no damage is occurring? Next slide, please. So let's have a look at incontinence and assessment and care of incontinence. And we tend to talk about incontinence for pressure damage as part of the OSKA and care bundle, but actually we can very much associate that, obviously, under the umbrella term of moisture-associated skin damage. And it's moisture, more importantly, that can obviously mean that the skin has to work that little bit harder, and obviously can have a real detrimental effect to the overall impact in terms of pressure ulceration. Now, obviously, moisture on the skin isn't a direct cause of pressure damage, but it can severely disrupt the skin in terms of being able to support the potential for pressure damage. So we need to look at moisture-associated skin damage as an overall umbrella term, and that will encompass 4 different conditions, or 4 distinct conditions. So we've got incontinence-associated dermatitis, or IAD. There is the get my teeth in for this one, intertriginous, should I say, dermatitis, which is where we get sweat trapped within skin folds. We also have peri-wound associated dermatitis, and that's normally down to high exudate levels from wounds, and where we get that kind of maceration and redness around the surrounding skin. Peristomal moisture associated dermatitis as well, so that could be from a stoma or skin junction where we're getting excess mucus coming away and moisture that's sitting against the skin for too long. So all of those conditions we can associate to ensuring that the skin has to, so not ensuring that the skin has to work harder. But let's have a look more at incontinence. So for incontinence, firstly, incontinence, we always tend to get a little bit stuck between what is incontinence and what is pressure damage. So in terms of incontinence or moisture on the skin from incontinence, what you'll find is that the damage will often look more spread out. Pressure damage is more localized, so it will have edges, it will be in a specific place, a specific area, whereas fluid, as and when it gets on anywhere, spreads out. So you will always see a spread out pattern on the skin. Skin will also always look shiny when there's moisture on it as well. It won't necessarily with pressure damage. And what you'll also find is with moisture, if it's certainly within skin folds, you get like a butterfly effect in terms of the pattern of damage. So what you'll get on one side of a skin fold will mimic exactly the same on the other side. And you won't necessarily get that with pressure damage. Like I said, you may get several areas of pressure damage, but they will be distinct individual areas. So as and when urine or faeces sits against the skin for too long, what you'll find is that it will start to disrupt the skin's natural protection. And we have our natural protective layer on the skin known as our acid mantle. And strangely enough, it is acid. And so therefore, as and when urine and faeces sits against the skin, which is alkaline, it starts to raise the pH of the skin. And then that starts to break down that acid mantle. And then what that then does is it leaves our top layer of our skin exposed, the epidermis exposed to the effects of potential bacteria to toxins, and that can then therefore cause that redness, that excoriation that we see, and that can be really painful for our patients. Next slide, please. And so what we need to think about is how we are therefore looking after the skin. And we need to be thinking about how we're looking after the skin after each episode of incontinence, and then how we're protecting the skin as well. So if someone's had an episode of incontinence, I'm sure you realise you would want to cleanse the skin. So you would want to ensure that you're using unperfumed soaps or soap-free cleansers, maybe an emollient substitute as well. And you want to wash the skin thoroughly, but you also then want to dry it. But you don't want to be rubbing the skin, you want to be patting it dry. So you want to take care of that skin because it's quite vulnerable at that point. If you do need to apply emollients, then please apply them lightly to keep the skin well hydrated. We want to try not to use talcum powder. In fact, I don't really think we use talcum powder anymore, and we shouldn't be using it. It can clog. I've actually seen little pressure ulcers from clogging in kind of skin folds and things. So we need to be really careful of using talcum powder. We try to stay clear of using oil-based creams, and Alison talked earlier about the Sudocrem. Absolutely, we need to avoid using that, especially if we're using continence products alongside it. Sudocrem is very thick. It can clog the pores basically of an incontinence pad, and I would actually say that barrier creams can also do that. Not every barrier cream, but some barrier creams can also do that as well. The thicker it tends to be, you tend to find that clogging effect on incontinence pads. And what you'll find is people tend to put on their cream or their barrier cream, and then they wipe the excess cream in the pad, thinking that they're doing something really beneficial, but unfortunately they won't be. And all you're doing is stopping the urine from getting through into that pad where it can get locked away. Whereas if the urine sits on top of that cream, then it's just going to sit against the skin and obviously cause the skin damage. So we need to try to avoid using those types of creams. If you're ever concerned about a barrier cream or any kind of cream that you might be using on the skin, get a little bit of the cream, pop it in a pad and pour water on top of it, because you'll see the water just trickling straight off if it will block the pores of the continence pad. So in terms of protecting the skin, following your cleansing of the skin, you would then want to be using a barrier cream, and that can be a barrier of some sort. That generally is cream that we would use, but you may also see them as sprays. You sometimes get lolly sticks as well, which those lolly sticks tend to be used more for kind of surrounding the surrounding skin on wounds. But you can use a variety of different things, and there are lots of different types of barrier creams out there that you can use, and I'm sure you've all got ones that you are using and are known to you. As and when you apply them, try to apply them sparingly. That tends to be as directed. So apply them sparingly so you can still see the skin through. And you only ever need to reapply them as and when you've washed it off. So once someone's had an incontinent episode, you've cleansed the skin, reapply it at that point. Other than that, it will stay in place. So you don't need to keep reapplying it. The other thing just to say as well, a good continence assessment is really key as well, to ensure that you understand the level of incontinence, you understand what products that they may need, and also you understand how often you can toilet somebody or may need to toilet somebody, because ultimately toileting is going to significantly reduce those incontinent episodes for some residents and patients. So please be aware of that. If you don't specifically do the continence assessment, there will be continence nurses that can come in and do that for you. Next slide, please. Oh, I'm handing over to Alison now.
Me, yeah. So this is just the last few minutes, everybody. Apologies, we have run over on our specified time that we said, and thank you so much, everybody, for staying with us. There's so much to get through. There's absolutely no way we can just do it all in an hour. We could stay here for, well, we won't stay for hours more. So, right, we're going to rush through this bit, and we can revisit this at another point in detail, and then we can get to your questions. So just to cover very briefly about nutrition, and for me in wound healing, nutrition, arguably probably the most important element. You know, you wouldn't put the wrong fuel into your car, would you? Because it just wouldn't go. So we've got the Eat Well plate picture there on the screen from the NHS. You can find that online. So we're promoting balanced, regular meals and snacks for our patients who are at risk or actually have a pressure ulcer. Fluid, of course, we won't forget that. So, 2,000 mils to 2,500 recommended. Obviously water is great. Not everybody drinks water, but if we can, reduce the caffeinated type drinks and alcohol, which are a diuretic and might lead to incontinence and falls. So if someone is malnourished, they are at a greater risk, but also if people have obesity, they can also be malnourished. It's not just people who are of a low rate. So we do in practice in all our areas, we do screening tools, and I think MUST will probably be the one they identify with using most. If you're not sure how to use MUST, ask in your work areas. There's usually some element of MUST training available, or on the BAPEN website, it does tell us there how to use it, because if we use it incorrectly, it can give us the wrong incorrect scores. So do look to that. Next slide, please. Oh, no, that one. Yeah. So protein deficiency is a big problem. When a patient has a big pressure ulcer, any wound that's leaking large amount of exudates, you are going to lose your protein and nutrients through the exudate. So it's important to replace that protein. So, what does that look like? How much is it? So I did a calculation. So it says on screen. So, how much per kilograms of protein for the weight of a patient does somebody need? So if somebody's 65 kilos, which is 10 stone, they would need 97.5 grams of protein a day minimum if they've got a pressure ulcer exuding a wound. So what does that look like, and is it achievable? So if we look on our next slide. Next slide, please. There we go. So that looks like in one day, not all together, but would either be 7.5 eggs, 250 gram steak, 4 slices of salmon, 2 massive pieces of chicken breast, and 24 avocados. I mean, not all in one go, but even individually, these patients might be unwell, they're not feeling great, they might be in bed, they've got a pressure ulcer, etc., etc., etc. Is this achievable to replace that protein they're losing? And the protein are the building blocks of wound healing. Maybe not. NICE guidance talks about supplementation. It does say food first, but if somebody obviously cannot, they have swallowing difficulties, they're unable to have that intake, then we have to work with our multidisciplinary team. So that'll be our nutritionalists, our dietitians, that might be via our GPs, via your tissue viability team. So supplementation can be implemented there. So I'll say we'll go over nutrition again a bit more in the future, because it's the subject within itself, I'm quite honest. So next slide, please. And so you'll get these slides anyway. So this is the calculations you can use in practice, how much increased energy, calories people need. So we can fortify diets, can't we? Put cream and milk and butter and things like that in as a side from the protein. And then macronutrients are the carbohydrates, those big food groups, the fats, and the micronutrients from fruit and vegetables, all the vitamins and minerals. Again, if these are not being achieved in the body, we might need to consider supplements. And then next slide, which I think might be one of our last slides. So we'll move on to the next one from there. So the end of our asking is about giving information and advice. We talk a lot about self-care and shared care now, especially through COVID and, staffing problems and everything we have. So it's important to make sure our patients are also on board, but people are being accountable for their kind of own health and elements of care. So this was added in, so it underpins and supports our pathways of care that we're giving. Do leaflets work? Again, is another debate and conversation. There is some research being done to say that people don't often read literature that's given, and also there's things like language the sensory problems people might have. Leaflets often, in the NHS, are often very, very wordy, and you see them on the side in patients' houses and things like that. So, you know, that there's evidence to say that kind of that verbal relationship is that's a really good connection, and people kind of listen to that. Do we need videos? And, you know, we're kind of moving in a digital virtual age. You know, so there's a lot of work and research to be done, but make sure we are giving advice and communicating, and we document it, because often in our root cause analysis in investigations, it will come up, and in complaints of care. So we've got litigation that, you know, oh, well, they never, you know, we were never told about that. We don't know about that. Don't assume patients don't understand. You know, we can put things into different terminology, or, you know, at least have a go, have those discussions and conversations. So that's the end of our asking. And I think we might have some burning questions, Emma.
We do indeed. They've been flooding in. We know from this back to basics session, the questions are many and varied. Your passion is undeniable, and like you say, we could talk for hours. So first question, I would like to ask you about the use of micro movements and bed tilts in pressure relief, especially for patients at end of life care. Also, is there any research or recommendations around this? Anybody want to pick that up?
Yeah, no, that's fine. I can pick that up. So yeah, in terms of those micro movements, I mean, ultimately, those tilting surfaces that look at micro movements is just trying to mimic someone's natural movement. So ultimately, we move roughly every 10-11 minutes. So as we've all been sat here now, I'm sure you've been seeing me shifting around. I'm terrible fidget. So ultimately, you know, we move, but our patients can't always move. So ultimately, you know, what we're looking at with those tilting mattresses is to mimic that movement. There is evidence, and we can send you, whoever that was who asked the question, we can send you our white paper on our lateral tilt mattress, which looks at that micro shifting. Doesn't mean to say that using those types of lateral tilting systems that you don't need to reposition. You absolutely should be repositioning, but they can help support that repositioning. So it may be that somebody at night, you know, ideally it's better for them to be able to sleep and not be disturbed. So therefore, it may be that overnight you can use that lateral tilt to support your repositioning over a night time, and then you would resume maybe during the day, depending obviously on your skin assessment, depending on your overall holistic assessment of that patient.
Thanks, Anita. Okay, the next one. Is there any guidance at all in regards to end-of-life care and repositioning? We understand it's vital to reposition patients 2 hourly during the day, 4 hourly at night, especially so for high-risk patients. But is there any documentation to help us with end-of-life care and pressure relief? I know these patients are at a greater risk of pressure damage due to their body shutting down, but surely we do need to include that aspect of patient dignity if deemed clinically appropriate. Carol, I can see you nodding there.
Yeah, subject close to my heart. So I think, I don't think there's anything really written and specific, but I think we have to consider that holistic assessment again. Does the patient have a lot of pain? Are we keeping that under control? Do they want to move? We need to do our best for them, but ultimately when somebody's at the end of their life, it's about comfort and, as you say, dignity. So it might be that we make very micro movements, or we use the equipment that can support them a little bit more. And it might be just moving a limb or adjusting a pillow might just be all that they can tolerate at that time.
Thank you. Another really good one. Again, could you please explain why not to use the term reactor red, as this is something my line manager has advised me to deliver?
I'll take that because it was me that mentioned it. I mean, yes, reactor red was quite a big thing, you know, not that long ago, really. And NHS, it was devised in one particular trust as a pressure ulcer prevention education thing, and it was taken by NHS England. They even put it into educational booklets, documents, everything else. I had a team in Bradford that was called Reactor Red. You know, we had that. But now, what we know with the emerging evidence and best practice, international consensus on looking at dark skin tones, when we're saying react to red, we are talking about one particular skin type where we have redness from erythema. So I think it's kind of, it's not, it's excluding a lot of people by doing that. I think I still see it sort of here and there popping up on Twitter and things like that, but I think going forward we really should be kind of putting that aside. We are using that, looking at redness erythema in certain skin tones, but also we've got to be inclusive of different skin tones as well. So it can be perceived as as a bias, to be honest. So it's good to have those conversations in practice. And the National Wound Care Strategy Programme that has the NHS pressure initiatives within that, I think they'd be happy for sort of discussions and conversations. Nobody's saying, right, that's it, it's outlawed, you can't use it, but I think it's about time we should be mindful of it.
Thanks, Alison. I'm very conscious of the fact that we have run quite a lot over. There's a lot of questions around end of life care. So if we haven't come to your question today, we will come back to you after the session and answer it on a one-to-one basis for you. It kind of brings me nicely on to the Pressure Care Champions Network. These ladies are all part of this group and they're there to answer questions. So if you'd like to join the group, just look for us on Facebook. You can see the picture there and we'll link it in the slides when we send them out to you a little bit later. But it really is a great platform to ask these kind of questions and get this kind of expert advice from these ladies. It's full of tissue viability nurses, OTs, district and community nurses, as well as some carers as well. So great platform to meet other people and to chat. Okay, ladies, again, thank you. A really great session, full of passion, full of just expert knowledge. I've learned a lot and I'm not a clinician. So to everybody that's joined us today, thank you so much for joining us. We hope you've enjoyed the session and that everything that you've learned today, you can engage in your day-to-day working environments. If we've talked about any equipment and you'd like to trial it, please let us know. We're in the process of planning future sessions and we've got a couple of save the dates coming up. So let me just try and bring that slide up for you. So we're going to talk about dementia next time and also diabetic ulcers. Today's session has been recorded. A lot of you have asked about that. The slides will be sent out to you as well as the recording, and also don't forget it accounts for CPD learning. So we'll also be sending your personalised certificates. And of course, if you'd like to chat to any of these ladies, do reach out to us using the email address nurse@osca.uk.com. So all that leaves me to say is thank you again. Hopefully we will see you in April. And ladies, my sincere thanks again. Have a great evening, everyone. Bye.
Bye, everybody.
Bye.
Thanks, bye-bye.